Good morning, everybody. Thank you for taking out the time to come to my talk. I'm going to be speaking on a congenital neurological disorder called Angelman Syndrome. And what we saw was basically a patient. So, the outline for my presentation is going to be I'm going to start with presenting the case, I'll walk you through a little bit of the introduction of the background of the disease, how prevalent it is in the United States, common physical features seen in these patients, their sign and symptoms, the pathophysiology of the disease, diagnosis, current treatment and management, and a highlight on current research and therapeutic modalities, and how do people who have Angelman syndrome and their families live with it. So what happened was we had a 21-year-old male that presented to the OPD with his parents for follow-up after suffering from chronic seizures almost once every 2 to 3 weeks since he saw us in 2016. And when we asked the mother if there were any complaints when he was born, were there any complications with her pregnancy, she mentioned that her child was born via spontaneous vaginal delivery at 40 weeks. The baby was growing well up until 18 months, and that was when he had his first seizure. And at 18 months, he had his first seizure, his crawling was delayed, and then he had tremendous difficulty trying to walk compared to kids his own age. At that point, his mother became very concerned, and then, she went to the doctor. And at the time, and since the mother's origin is Russia, she was in Russia at the time, she went to see various physicians, but whatever medication that she was being prescribed didn't seem to be working, and her son's seizures continued. And she was told, though, that her son has a congenital intellectual disability, but it was never confirmed which one. So when we saw her in 2016, we prescribed her a dual combination of Valprix, 125 milligrams, 5 tablets, delayed release sprinkle twice a day for 90 days, and lamotrigine 25 milligram, 1 tablet twice a day for 30 days. And it was very nice to know that the mother mentioned that the son no longer had any seizures. And when I saw him, I saw my patient for the first time on the 19th of July. And the very first time when I saw him, I noticed that his features were very unique. He was constantly smiling. He was, very energetic, and he had very prominent teeth, but he had a kind of like a small jaw. And he appeared to be very friendly, and he was very excited to be there. And when I questioned them further, the parents told me that he also had a history of scoliosis, and they reported that when he did have his seizures, they were about 5 to 10 minutes long, and they were accompanied with eye rolling, dystonia, and urinary incontinence. The patient also has a stepfather, and he seems to have a very good relation with him, which is also important because we oftentimes see that patients who have intellectual disability tend to fall under abuse, and it usually goes undocumented because of their inability to communicate. And the one thing that we should always ask patients or families of Angelman syndrome is how are they doing? Because these patients have a tendency to be have a very difficult time falling asleep and have a tendency to be very hyperactive, and so they can stay up for like long hours, about 24, 26 hours. They wake up in the middle of the night, and it can sometimes take a toll on the caregivers because they don't get sleep, which is, nobody's, we wouldn't say it's, like anyone's, purposefully doing that because the child doesn't know any better, but it is always a good thing to ask how the mother is doing and how the family is doing and how things are. And his vocabulary only consists of 2 to 3 words. And this was an interesting fact that his stepfather mentioned, that when there's a tile with different colors, he doesn't like to walk until somebody holds him. I just thought it was interesting to put because I haven't heard of that something like that before. But he denies that he has any current seizures or progressively worsening symptoms. Our patient's symptoms were well managed, and he had no headaches, falls, or dizziness reported recently. Um, he did have a family history of focal seizures in his maternal aunt, and his older brother, who is biologically his older brother, goes to college, and he does not have any intellectual difficulties. So on general appearance, we saw, like we mentioned, a very cheerful, very smiling, thin young man. He was accompanied by his parents. He had one eye was amblyopic.
Sorry, yes.
And he had a small face, prominent big teeth, wide, a very big smile and a small jaw, and he had a wide base gait. When I was doing his examination, cranial nerves could not be elicited because the patient could not follow command. But we noticed his one eye was amblyopic, and when I was monitoring his strength, so the patient had a tendency to come and like want to hold your hands very tightly. So that was one way I was able to discern his motor symptoms. But we noticed that when during his physical exam that he was continuously flapping his hands, he always kept them flexed, and his parents mentioned that he was unable to make a fist. And aside from that, we saw muscle atrophy, hypotonia, which was seen in all four extremities. And it was very interesting finding is that patients with Angelman have difficulty extending their legs, and it's basically stiff, and it's called arthrogryposis, and it's a difficulty extending your leg, which we thought was interesting. But then we also had a few features which we were sort of interested in because normally patients with Angelman syndrome have small head circumference, like microcephaly, and our patient's head circumference was normal. So then, we decided that, we should not just, think of Engelman only. So we also put autism as a differential. And then we also decided to do an MRI of the brain. We decided to do an EEG, and we decided to do a CMA, which is a chromosome microanalysis array, alongside some routine blood work to make sure that his electrolytes and blood work are good. And so the disease Angelman was first described by an English pediatrician called Harry Angelman, and he basically was working with, or he saw three children who had, like he said, a very smiling character and stiff, jerky movements. And one day he went to Italy, in a museum, and he saw this painting. There was a painting of a boy who was painting a puppet, and that sort of inspired him to sort of write a paper called Puppet Children. And that's how he wrote this first paper describing these three children as happy puppet children. But the title was only used up till 1982 because people felt that it was sort of offensive. So then they just started to call them Angelman, like as the disease is Angelman syndrome. So what we understand of this disease is that this is a rare disorder with affecting 1 is to 12,000 people, and males and females are affected with equal frequency. And so what happens is that there is on chromosome 15, there is a deletion or a mutation of the gene called UBE3A. And so the mutation can happen by something that we are constant when we're taught in med school is a methylation. And it's basically an imprinting. And what we understand by that is turning off. So the imprinting through methylation turns off the gene so it doesn't work. Another variant is that it just deleted altogether. And so the interesting thing about this disease is that with Angelman, uh, in your central nervous system, you have a physiologic imprinting of the paternal allele. So it's only the maternal one that's active. And so in these children, when the maternal allele also gets inactive, that's when they start getting these symptoms. And so what we see is initially mothers would report that their children are normal, they're growing well. But then about 6 to 12 months when they start crawling, they're babbling and their crawling is just delayed. And that's when the mother starts to get concerned. And then seizures may begin around age 2 to 3, which is what also happened with our patient. And it's good to know that Angelman syndrome patients tend to live a very normal lifespan, but the disorder cannot be cured. However, there are some interesting new researches which are trying to solve that problem. And currently, we focus on symptom management, sleep management, and developmental issues. So if you look at this child on the left, you notice that there's like puffiness around her eyes. She has telecanthus, which is like an increased distance between the inner eyelids. She doesn't have, it doesn't appear a very sunken nasal bridge, but most of them do, with a very wide mouth, with an ear to ear smile, a long philtrum, a very prominent lower lip. Uh, they have a tendency to drool more frequently. They have a small head. And if you look at this patient's hands, you notice that there's tapered fingers, some abnormal creases and broad thumbs, and they're always very happy. So I put this picture up just to show you because so these are picture A, B, C, and D are patients of Angelman syndrome at different ages. But if you look at it, you would probably see some very similar features. And there you see in picture A here these very prominent teeth, and over here this very smiling face, and sort of like microcephaly here, and like a wide base gait. And so the reason I want to keep these pictures here so that you sort of develop um, a memory, and when you see these children you can sort of like pick it. It's like, okay, I've seen this before. And so interestingly, we know that consistent features are basically symptoms that we see in almost all of our patients, and that, like we mentioned before, is developmental delay, which starts 6 to 12 months, functionally severe intellectual disability, behavioral problems, frequent laughter, very happy, very hyperactive, and balance problems by age 3 and speech impairment by age 3. Frequent features means that they may be present but not all the time. And it's interesting that seizures is on the frequent feature side. We also have microcephaly, which we were sort of wondering if that could be, that was actually on the differential of maybe this is not Engelmann. But it's interesting that it's a frequent feature but not always consistent. They have GI difficulties, feeding problems, they have GERD, and it's very interesting that they have this fascination with water. And that is something that also patients with autism seem to have in some cases. And it could be because both of them have uh, they're genetically similar in what genes and chromosomes are affected in both diseases. Insomnia, angle pronation, and mouthing behavior. We occasionally see scoliosis, which we did have in our patient, hypopigmentation, or like very like pale skin, increased temperature sensitivity, and ocular symptoms. And so the pathophysiology is what happens is that on chromosome 15, we have a methylation of the UBE3A gene. And then once that lost, and the UBE3A gene is actually responsible for speech, for movement, and for learning. And so that gene was actually coding for a protein called the ubiquitin protein ligase, which you all probably know as an enzyme, which is responsible for targeting degradation within cells. And so that doesn't happen. And then, like we said, in the CNS, only your mother's copy of the UBE3 is expressed, and the copy inherited from the father is silenced prematurely by a mechanism called the antisense transcript. And so what happens is that the father's copy is sort of like blocked by this non-coding, like there's a neuron that makes a non-coding RNA, and that sort of blocks the father's expression. And so, which is why um, we have the problem. Now, if you understand the pathophysiology, you may be able to understand why researchers are targeting. They're saying, okay, why don't we try activating the fathers? Why can we try that? Or why can we try, finding an exon which can sort of, like use a virus to use as an exon to like target the UBE3A. But understanding the pathophysiology can help us understand the disease so then we can find a cure. It's only through that we understand the foundation that we can really think of a cure. So I think this is why this is important. And so we talked about maternal deletion, which is 75% of the cause why these kids have, genetic problems. Paternal disomy, uniparental disomy, is 7%, which means that the child gets 2 chromosomes from the father. And that's actually pretty high, 7%. And then we have the mutation that we talked about, the UB3A mutation, which is about 5%, and then other defects. So what we do for these kids right now is we have some tests. So what we're going to do is we can do a chromosome microarray analysis, which detects missing or mutated chromosomes. We can check FISH, which can detect deletion in chromosome 15, DNA methylation test to detect inactive genes, UB3A sequencing, clinical diagnosis, because it's interesting that there's so many patients with genetic issues who cannot get tested because insurance doesn't cover it or the price is exuberantly high. And so at times you have to rely on a clinical diagnosis to make an assessment. And not everybody can afford that, the genetic testing. And then we do EEG to diagnose seizures and monitor abnormal electrical activity. For these patients, the most common one is high amplitude rhythmic triphasic 2 to 3 hertz high voltage activity. You can also have 3 hertz spikes, which is an absence seizure. You can also have polyspikes, which are 2 to 3, which are, I think, myoclonic seizures. So the seizures are the most common one is this, but you can also have like variation in what you see in the EEG. And so when we give them anti-seizure medication, the most commonly used are the levetiracetam and lamotrigine. And we both know that lamotrigine is acts on the SVB2. It's like a neuromodulator acting on the SVB2, so that increases GABA release and relaxes sort of the electrical activity in the brain. And both of these drugs sort of, and levetiracetam, if I'm correct, inhibits glutamate release. And we do physical therapy, which helps them improve posture, balance, walking ability. And it's good for them to be prescribed physical therapy because we have to prevent permanent stiffening of the joints. Communication therapy is good. So what it does is aids them with nonverbal language skills and sign language and assistance using visual aid. We now have these apps on our iPads which have these visual cues and the kids can point to it. So I think that's also good. And then we have behavioral therapy, which we recommend to help overcome behavioral behavior in and when parents find symptoms hard to manage, like difficulty sleeping and hyperactivity. And so current research, I had looked into this library called, this is the NIH Library for Clinical Trials. And what's happening is, if you notice, we currently have 31 clinical trials, and the ones that I shortlisted were two. One, which was like more frequently seen, was they're trying to do a clinical trial of levodopa therapy in Angelman syndrome, and they're trying to evaluate the efficacy and safety of minocycline in Angelman syndrome. One of the studies that I read with levodopa did not show significant result, but it did. But the one I read for minocycline suggested that minocycline has a tendency to affect the dendrites in a way that they promote synapses, and they actually found some improvement in communication and fine movement in patients who were on minocycline, which is technically a tetracycline. So I thought that was interesting. And so there's a lot of other studies too, but these seem to be popping up more. So something we could read up on, to understand better and see if at least we can improve our patients symptomatically. That would be wonderful. Yeah. But thank you so much for your time. I hope you enjoyed the presentation, and I hope we all become better doctors and better physicians because of it. And have a lovely day.